So with that, welcome again to today's webinar on treating pain does not have to be painful. And very excited that we have Dr. Amy Moore here from The Ohio State University. And thank you again to our partner Tissue for sponsoring the opportunity today to talk about this important topic. I have the pleasure of introducing Dr. Moore, who really needs no introduction. She is a world leader in the peripheral nerve space, is both a professor and chair in the Department of Plastic and Reconstructive Surgery at The Ohio State University. She specializes in peripheral nerve surgery for acquired injuries and peripheral neuropathies in both the lower and upper extremities. She completed fellowships at both WashU and the Mayo Clinic, and her research is focused on developing treatments to make nerve regrowth more efficient and faster. And she has published over 100 peer-reviewed journal articles, so we are in very good hands for today's webinar. We're very appreciative that she's also a member of our education committee. And with that, Dr. Moore, I will turn it over to you.
Awesome, Steve. Thank you so much. That's awesome. And glad to be here. And so let's share my screen. How do we look? Yeah. Okay. Fabulous. So it is an honor to be here, and I'd say good morning, good evening, good day to you all. And I have the simple disclosure of just thanking Titium to, help sponsor one, being able to speak with you all. But also it's really important for us to lean into our industry partnerships to move this field forward in nerve surgery. And, when talking to Titium, their product isn't yet available in the US, but, they're like, well, whatever topic you want to speak on. And I have total mad props to that. And so I will mention a little bit later about where we're going and why I'm excited about their product and why I've been involved with them. But really, today's to talk about pain. And, as a nerve surgeon, I would, want to acknowledge both my patients who have helped me learn how to treat such horrible neuropathic pain. And when I wanted to become a nerve surgeon after spending a couple years in the laboratory, Dr. McKinnon said, well, if you want to be a nerve surgeon, you got to be able to lean into your patients with pain and not run from it. And I think that guidance was spot on, because there's a lot of cool things we can do with patients with nerve injuries. But if you do a wonderful, cool repair and the patient has horrible neuropathic pain, they will not use that reanimated limb. And so that's sort of the basis of today's talk. People only get to see what they're prepared to see. And if you look for what is good, you can be grateful for where you will find it, because you'll find it everywhere. And this quote I use more because I come from a place of gratitude attitude, that there is patients who can drive us, but they're in our office to because they need our help, and they're not there to I see a lot of times with my residents, they want to just move past the pain and get to what the problem is functionally. And I'm asking you all now to sort of open your minds to think about, well, maybe I should be asking every patient about their pain. It is the first thing I talk about with my patients in my clinics. So what is my practice? I treat 100% nerve patients now, and I have a big role in leadership, and that takes, but I'm 60% still clinical, and that is something where I want to set my timer so that I'm not going to screw this up with us. So forgive me, but I'm setting it now. But now I get to do all of these great things that's listed there. And the majority of my patients have leaned into this neuropathic pain, who've come to me as a Hail Mary referral. And those who may not be in the US, this is in football, American football, a long, typically unsuccessful pass made in a desperate attempt to score late in the game. And that's how I feel. I am a revision surgeon, and I have the patients who have seen multiple 5, 10 or more providers, have had multiple surgeries, and they come to me with this, you are my last hope. And I will tell you, talk about gratitude attitude. This is a privilege, and it is not lost on me. And I hope that unless it, that I can lean in and that it won't be an unsuccessful pass, that this will be, the home run. And so I do feel very grateful for what I get to do every day. Looking at when I came and jumped from Washington University to Ohio State, we really leaned in the first few years of where are my patients coming from? And I get often asked, how do you build a nerve practice? And it is through these relationships, right? Relationships with my patients who followed me, who find me through, giving these types of webinars. Truly grateful. It's through my colleagues, right? The majority in orthopedic surgery that it came from, let me help you with your worst patients. My relationships with my hip surgeons and my shoulder surgeons are probably right now my highest referrals, because nerves are everywhere, and you could do a great hip replacement and that patient get irritation from the lateral femoral cutaneous nerve, and that is for me to help take care of them. So we see this mutual respect, and this is how I built my practice. Now, I do get many emails and I welcome them. If you have a patient with, you want to chat with me or you want to send to me, I welcome it. It is such a privilege, right? But this is a typical one. This is coming from a previous Hand Society president. I have a difficult patient. She, has thoracic outlet, wants to hear from this about you, and CRPS. She's been reoperated on multiple times, but she's not very happy. She's diagnosed with this, and she's kind of a disaster. So I look at this and, my response is yes, let me help. Send this patient to me. I may not be able to offer a surgical solution, but what if, right? That's the question we have to ask ourselves when I'm doing, screenings of the referrals. What if I could help them and change their lives? And so I think it doesn't have to be painful. It really doesn't. So let's talk about pain a little bit. When I speak to patients, I talk about brain pain and I talk about peripheral pain, and we have to address both. Brain pain, centralized pain, unfortunately, too often, I think patients get labeled with this erroneously, right? Those who may have it, also have these things that are listed. Really traumatic event. The patients can talk about this over and over again, what happened to them. Patients who've had multiple surgeries are more likely to have this brain changes, and intense postoperative pain. Those are the patients who woke up and they said, I had horrible pain. They couldn't get in control of my pain for the first 24 hours. They had to admit me. They didn't expect to do that. And then the last thing to say about, brain pain is that I can't predict it. I can't predict it, but I ask about it. And this is a super, over, a very complex system. I put it there, that's not because I know anything really about it, but just to state, as an exam, that we don't know what the brain has, but I never use brain pain or the longevity of somebody who has had pain as a reason not to consider operating on them. And so that's my brain pain. And I think about that of, okay, well, how do we fix that brain pain? That comes with neuromodulation and medications that I'll talk about in a little bit, but also refers to it, of, counseling and trying to get support systems outside of the surgeon. And then we have the peripheral pain, and this is where the surgeons come in. This is where I think we can intervene. And mechanical pain is, often the driver. So not just this CRPS that everybody can see as they walk in the room, but, where does the etiology and thinking about these things that are listed can lead to it. What I find in my practice that I am searching for is where is that proximal injury that occurred that's leading to this vulnerability of compression that's accentuating the pain, right? So I was seeing a lot of amputees for a while, and yes, we were performing TMR, and then I was realizing, well, they are super, whether it's from immobilization or from the trauma itself, super painful proximally at these compression points. And so the idea that the double crush syndrome exists, I think full-heartedly I embrace. And that's that you have a proximal injury that leads to the nerve to swell. The swollen nerve is going through these tunnels that are fixed. And this is this pathophysiology of chronic compression. And not all neuropathic pain comes from chronic compression, but I think a majority, that those with thoracic outlet, which is, something we'll just touch on, but all of it comes down to is the size of the nerve through the space which it has to pass and the time through which it's been compressed. And I talk to my patients that nerves are like 4 lanes on a highway. You get a traffic accident or you get some construction, and what happens? The lanes go down and the traffic backs up. And when we think about with nerves, there's this known pathophysiology that's been so well drawn out with carpal tunnel and cubital tunnel, that as you have that compression of this swollen nerve trying to get through a space that's fixed, as the lanes go down, you get pain with those small fibers, numbness and tingling, persistent pain, numbness and tingling. And then when all the lanes go down and the axons get injured, you get weakness. And so my goal is to, one, identify where is this happening, not be afraid of it. I want to look for it, not just the cut nerve that the patient's now been turned in and have this posture of pain when now their pec minor is tight and they're now no longer able to extend their elbow and extend and adduct and externally rotate, right? There's things that we need to be looking for that can contribute to where they would just had a digital nerve injury, but how is this whole arm affected? It's because of these crush and compressions that could be happening more proximally. And then last but not least, when we're thinking about pain, we have to understand the psychosocial issues that are there. In this study, and there's many, that there is a high likelihood, if your patient has depression, that they have a higher likelihood to have chronic neuropathic pain. And those are the same thing, chronic pain for those who will have depression. I mean, how could you not if you're in pain every day, right? And the idea that you want to just be the nerve surgeon fixing the nerve that's injured, we have to move past that and ask our patients about their quality of life and get them the support. I don't want to be the psychologist in the room. I often have this role, but we have now built a team around that to help take care of these patients. And I ask about this every time. It's on my questionnaire. I'm talking to them, not because I want to run from it, but because I want to lean into them. Patients who've had a brachial plexus injury, by their time that they get through their first 6 to 9 months, it's just about just getting through the surgeries. But then they hit, and it hits with the reality that this is a life-changing event for them, and that pain is contributing, and we need to lean into these patients. When we started down this path, I was still a resident at the time and then moved into a junior faculty. We were getting a lot of resistance from our referrals in our system. The neurologist saying that if we operated on pain, we will create more pain. And so we were able to look at patients who underwent neuroma surgery, and what we were able to find is that we could improve their lives with operating. And so, yes, we had strict criteria that we chose these patients, but we could improve their quality of life and we could help their pain. So more surgery didn't mean more pain. And that's where I come from in this place that I learned under the leadership of Dr. McKinnon. So how do we do it? We do it with the idea that that it's going, history, exam, clinical studies. I'm just going to tell you the history for me matters the most. I look at my pain questionnaire that every patient gets immediately they come in. I come in and I look at this, and this will tell me they may think they have carpal tunnel syndrome, but if they have all these drawings, yes, it's carpal tunnel syndrome right? And it tells me how severely it's affecting their quality of life. And every patient fills this out before I meet with them. And it's the first thing we talk about because it sets the stage of what I need to be focused on. When we think about not all pain is equal, and even though they may come in with nerve entrapment as the diagnosis, a simple, pain diagram here on the left is different than the patient on the right. But I will tell you, it'll be my approach, but I think it's the same when I'm looking for it on their physical exam. What I was very interested in was, what are the patient medications that they come with? And when I came to Ohio State, when there wasn't much nerve surgery being done, it was very apparent that there wasn't a one-stop place that was giving patients medication to treat their nerve pain. And that, our pain specialists were pretty focused on the procedures and not necessarily managing medications. And I get it. We're all running a business in the bigger picture. However, most of our patients who came with these horrible chronic neuropathic pain weren't being treated pharmacologically. And that gave us an opportunity. So, when I think about making the diagnosis of history, we have to think about what are their medications are they on, and I will touch upon this of how we can fix that, and not be afraid of those medications, and then we ask, okay, what kind of surgery have you had? And so I'm giving only one slide to this. I hope, I don't know, I might have kept more in, but for the interest of time, what matters is revision surgery is thinking about three things, and that is it persistent, meaning the patient never got better. Then you're going to think, okay, well, maybe I had the wrong diagnosis, or maybe, I see it often when patients get their carpal tunnel release, but really where their proximal, forearm is where they're compressed and they don't understand why they didn't get better. And then the other part is recurrence. So they've had a period of time where they had this improvement of their symptoms, but then they develop inflammation or scarring, and then their symptoms recur. Or is it new? And this is the one that we can't put our heads in the sand. We need to lean into. Why are they numb in a new distribution? Did we kink it? Is there a reason? Did we injure it? And so those are things we need to be thinking about from a history standpoint when we're talking to our patients who have pain. So, and these slides are there. It's sort of simply what I just talked about, with the idea of persistent pain. We got the wrong diagnosis. That's the first thing I'm thinking about. You never got better. Double crush comes into play because maybe it's something that proximally they're crushed, so distally we go release it. It's not enough. Recurrent, they had that period of time, and it's in the literature, there's high recurrence rates. It's not to say that the surgery done the first time wasn't great. It's just that things happen, and that space through which that nerve is passing has closed down again for other reasons. And the one we don't want the patient, where you find that the nerve's been transected and you've gotten to a point where their pain is horrible, they have new changes in sensation, and we didn't find it. So physical exam is what I lean on. It tells me, all these clinical compression things are clinical diagnosis. People ask me, well, what about these clinical studies to prove that you can help them? I don't have it. It's really hard to get things published because a lot of this is just intuition of how is it working. And so I think about this as my physical exam. Yes, CRPS, you can see it when you have it, but these are the places I go from head to toe. I do a muscle exam, and then I do a compression exam, and finding the areas that may be less less recognized, I should say. I'm always thinking about the neck, pec minor. Man, pec minor is under recognized. And this pec minor, this muscle is vestigial when we walked on our hands. It has a direct, impact on the scapula, right? So it's pulling on the coracoid, internally rotated. This is the patient who's been in a posture of pain. This is the weightlifter who's been doing all these shrugs and really overdevelops the upper trap, and the lower trap gets stretched out and weak. And so all they're doing is scapular dyskinesia now with the scapula because of this entity. Complex regional pain syndrome, I talk on it because, there's a lot of interest in it. And I will say, I don't fear operating on CRPS. I have not seen somebody flare in the hundreds of patients I've cared for with CRPS. I've not seen somebody flare when I have found something surgically to intervene on. And that means that there is some kind of current compression or a nerve injury that I can identify on my exam. And then I lean in and I'm not afraid. Thoracic outlet, this is a diagnosis of exclusion. And you have, I'm sure, other talks that are fully on thoracic outlet. Diagnosis of exclusion, I promise you, it comes down to a muscle imbalance. I just recently helped write a chapter for Dr. McKinnon's new book, and that's not a plug. I get no royalties. But a lot of the literature can tell you that this muscle imbalance is real, and we may be over operating on these patients, but really the idea is to make sure you're looking for it. And too often when your surgery doesn't give you the result you want, want, we'd label them, oh, they're TOS, send them to Dr. Moore. And I say, thank you, let me see it. And I never say, okay, you have thoracic outlet. I am looking for the etiology. Where are you compressed? Where are your muscles unbalanced? And yes, you've had years of therapy. Well, you haven't had it with my thoracic outlet PhD trained PT. Let's let them examine you and help you get a home exercise program before I operate. I don't use these tests. Like it's really interesting. Yes, they may be, but if you're me, I do this, my hand goes numb, right? Like all of these things are non-specific, but I really think about what their history is, where are they tender, and let them tell me where I need to be. Now I look at the scapula, and so this patient is this thoracic outlet. So you're going to watch this left scapula and it pops out, right? So he has this weakness of those lower traps, and you can see how muscly he is. He had had all of his other nerves released before he came to me, and I'm just watching. It takes 3 times thumbs up, straight ahead, up and down to watch this shoulder blade do what it's going to do. And so this is simply from him being so overly upper trap turned in, and then the strength that's leaving his shoulder blade weak. It's muscle imbalance. That's his guy's going to therapy before I'm going to release his pec minor or his neck. Now, if he fails in therapy and he's not progressing, he may need the pec minor release, but I'm going to do a pec minor release before I go up to his neck. And there's other ways to talk about that. Um, Clinical studies, I use ultrasound. I have an ultrasonographer, Jeff Strakowski, who has been an incredible partner, objectively looking at these patients. He's not in my clinic. I'm not doing it myself. I don't have time to do it. I should. Maybe that makes me a poor clinician, and I welcome those comments. But I honestly, I have a good partner helping me. I do get the electrical studies, but the electrical studies are often normal or they're unchanged from their preoperative state. And what do we do with that? It's not that they're normal, they're patients in your office with pain. And so I use them as an adjunct, but they are not going to drive it. It may help me that, like, if they're having fibs, it tells me the severity, that there's an axonal damage in addition, likely as a possible source for this pain. I don't use much else from it, from the other things listed. So my perioperative care, if we're getting that physical therapy, the desensitization, I'm talking about pain, we're going about counseling, and the most important thing is I'm setting expectations. With you coming with me with neuropathic pain and maybe something I can treat, our goal isn't to get you pain of 0. Our goal is to drop you 3 points on a visual analog scale. Our goal is to make your quality of life better than today. And I can't give you a percentage of how many and how much you're going to get better, but I will tell you our goal today. If I feel like from your exam and from your history, I can indicate you for surgery, we can make it. I mentioned this briefly about PT, your tight muscles that are leading to this stretching out muscles, this muscle imbalance. It's real. It's not heavy lifting that you're going to add to it. It's real if you can find the right therapist who will work with you and your patients, understanding you as the surgeon, what the limitations are. Now you may want to take a screenshot. Again, this will be posted, but the neuromodulation, these are the big guns that I use in my clinic. I am not afraid of prescribing these medications. I don't need to send them to a psychiatrist to write them. I don't need to send them to their primary care. If a patient comes on multiple medications and I'm concerned about interactions, then I send them back with my recommendation and ask for them to look at those medications so that I'm not responsible for those interactions. But if they are coming to, and most are, without anything, I'm starting with a low dose Lyrica, 25 milligrams in the evening, that's pregabalin, and then we slowly increase it. Add in 5 days, if no symptoms, somnolence, rage, then we add a second dose in the morning. We're slow to get these going. If your patient is in this perimenopausal age group of women of 35 to like 55, 60, my first line is Cymbalta duloxetine. And I started at low dose, which helps neuropathic pain, because I'm not really sure why, but our hormones are where they are. And I think that this has been a game changer for my women with neuropathic pain. So here's how it works. Preoperatively, I'm starting them on a medication for that brain pain. I want it present for 6 weeks prior to our operation. They're also getting that PT. Intraoperatively, I'm using ketamine for all patients. And then I've started using a medication called Zen Relief. Again, I have no conflict of interest with them, but this is like a honey and it's locally delivered. It dissolves over time, releasing Marcaine and meloxicam. Game changer in my practice. I no longer leave any indwelling catheters. It has been amazing. If the patient has had a history of ketamine infusions, peripheral nerve stimulators, then that is all handled by my pain team. And that's very, very rare. My patients are outpatient 99% of the time. Counseling, they're going to get that recommendation to see somebody who can help them with them symptoms. I also urge you to ask the caregiver. I kept seeing patients, and the patient is there, and the caregiver is answering all the questions. The caregiver is crying, and all I can say is, "I can help your loved one, but you are suffering." And I wanted to prove it to be true. And caregiver distress is a known entity in breast cancer or cancers or any diagnosis that are leading to high morbidity. But we were able to prove it true, and this is in revision for publication. But what we did was look at both scanning the patients as well as the caregivers. This was their demographics. We looked at, a visual analog scale. We looked at their patient health and their distress thermometer. And we found that patients with nerve injuries, they have pain, they have anxiety, depression, and higher than the normal population. And if you could see that these were there, the caregivers had it too, higher than what normal population would be expected. And so what we can find is if you're seeing it in your patient, you should ask the caregiver. We're working with our psychologists and psychiatrists right now with how do we intervene for the caregiver. And so stay tuned, but this is real and it's not being afraid to ask the questions. You don't have to have the answer, but acknowledging that with your patient and their caregiver goes a very, very long way to the ultimate global treatment for these patients. It's really key to set clear expectations because you are not superhuman. A lot of my residents and fellows come through my clinic and they're like, I don't know how you do it because it can be exhausting. It can be exhausting in the sense of, thinking that you've done the best surgery and they haven't had the best outcome, or the years that it takes for them to see and improve. And it's really more months than it is years. And you can't predict who's going to have life-altering pain. But what I can tell you is that you need to lean into the patients and not be afraid of it. You don't have to take care of all these patients if you don't know what to do, but find somebody who can. And often it's not just sending them to the pain specialist. That should be your partner in caring for these patients. Look, listen to their history, find something on exam that could potentially be the reason, and don't be afraid to intervene. 3 points on that VAS scale is significant. And I will tell you, we talk about this with our patients like nauseumly, like we do all the time, because they need to know that it's not going to be normal. We're not going to normal, we're going to better. And that better is only defined by them. And so that has to be set very soon. Now, what can we do to help patients with pain? And this is, this is beyond the scope of this talk, is to talk about what I do specifically for pain, but it can come back with, these topics that I'll just give a little bit of an overview for. And the first is restore anatomy. If you know where the nerve is injured, you need to explore it to see if you can repair it. And repairing a nerve and giving that nerve something to do with its normal target allows the brain that just a little bit of a benefit to get there. And this is where I'm going to take the opportunity, and forgive me for digressing here, but I think it's actually really important that we're, aligning with our industry partners to push this field forward. And, I haven't physically been able to have patients using this Coaptium Connect device, but I'm super excited about it. And why? And why am I excited about it is that, the basic science is really powerful. Like, what do we care about with our coaptations? And we know this matters at the site, matters where we do this repair. If you do a good repair, you don't have tension on it. You're not going to lead to neuroma that can then lead to pain. It all follows forward. And they were able to show in this paper that, using the polymer assisted non-traumatic device, that you could get great tension and biomechanics on it. When put into, an in vivo um, study, they were able to show that, and I care about this and I talk about this a lot, and people are like, Amy, I can't believe you're talking about doing coaptation devices. I welcome it now, right? Because the reality is I care about the inflammation. Well, they were able to show that it didn't increase more inflammation around the nerve. Inflammation on a nerve, if you put a wrap on too tight, I'm sorry, you will cause inflammation. If you use a wrap that the patient wants to reject, you will cause inflammation. And so I'm really careful about, what I'm thinking about is because I want inflammation to be minimized. I want the coaptation to be strong, and I want to be able to minimize the amount of pain that they're going to have at that site of repair. And they were able to show, polymer assisted versus sutures, there was no statistical differences, which means that, it gives us an opportunity. And the study that's been happening in Australia, this is where they had 10 patients that have been done. It's the first in use in humans, showing that there is, from ultrasounds, from multiple different outcome measures, that they're seeing recovery across using this device. And so that's what I have to say about it. I'm looking forward to getting it hands on it in the US, and thinking that there's new ways for us to improve the care for our patients that might also help their pain. When I think about neuromas, I think about, we are doing something new, right? Like this is in 14 and 15, 2014 and 15. We started hearing about targeted muscle reinnervation and regenerative peripheral nerve interfaces. And that was when I was started looking, okay, well, what are we doing for neuromas? And under the great, work of Lewis Poplar, we were able to do this, analysis of seeing, okay, can we reduce pain in patients? And we in this analysis, we've had 1,300 plus patients. And what we showed is that surgical treatment was effective in 77% of them. We can help patients with neuroma pain by finding the right patients by their physical exam and history. And it didn't really matter what you did. But this was prior to these new techniques of giving the nerve something to do. And this is where I have huge respect for Dr. Damani and Sederna and McKinnon, who knew that their patients, that it's 77%, that means that there was 20 something percent. You guys can do the math, forgive me. You can do, that there's that opportunity for those other patients that we can help. And I think now if I do that study again, which I probably should, and if any of you have the energy, you should look at it with now TMR added in, look at it with now regenerative peripheral nerve interfaces added in. I don't so much use the nerve to nowhere with the acellular allografts, mostly because of cost, but it is an option, and I have still have used this in patients. The last thing to finish on, and I know we're at time, and I want to make sure that we have time for questions and thinking. So I have just a few more slides. This was the paper that I had almost the hardest time, the most revisions to get published. And I don't think it's because I'm a bad author or scientist. I think it's because there's a nuance to trying to understand how do you indicate somebody for surgery for the treatment of pain. So what my mentality is, if a patient has pain with compression on this physical exam that matches and recreates the pain that they live with every day, then that's an opportunity for me to make the lanes back open, right? Make the bridge wider, give the space, the nerve, the space that it can have, minimize the inflammation that's present, and not to be afraid of doing multiple releases at a time, especially for the scenarios with patients who had a previous trauma. The patient who was walking their dog, they have the leash pulls on their shoulder is all worked up, that's no problem, no tears, but they don't understand why the whole arm has been in pain since. Well, it's because that whole stretch caused that plexus to stretch, get inflamed, and now that swollen nerve is coming down through these entrapment points. And so this study that you can look at, it was really important for me because it forced me to really think about who I'm operating on and can we help them. And what we showed is that we could. So here's a case example of the patients that come in. This is a 31-year-old PhD student, greater than a year of history of playing. Spring of COVID, started playing the mandolin. We all picked up different activities of COVID, and his was the mandolin. And discomfort in his neck. He had the inability to raise his dominant hand over him. It was affecting him how he could do his work. Super smart, thoughtful guy. And he was depressed because of his pain. And he has given me permission to share his story. So I should say that up front. He had seen 12 providers across 3 states, multiple physicians, naturopathic, chiropractor with no help. He's had this $1 million workup to make sure, and this is key, patients with pain and weakness, you need to rule out a tumor. You need to rule out the bad things. I'm very thorough, so I know it sounds like I'm being very nonchalant maybe at points, but like you need to rule out the bad stuff. I should have said that back with what do I use? So he had all the bad stuff ruled out, right? He had some pectoralis minor tightness. So on my exam, he had this palpable cord on the inside of his right arm, which wasn't present on his left. He had tenderness at his pec minor, tenderness at his median nerve in the forearm. He couldn't abduct without horrible pain, especially when his arm was in full stretch of the nerves, right? And then his left arm was totally fine. And his strength was normal. So he had been told, and all of his studies were normal, right? You're fine. It's in your head. You're crazy. But you know what? I didn't choose to take that narrative. I choose to think, okay, well, what physically could be happening? And I took him to the operating room. I released pec minor because of that whole internal rotation, his scapular dyskinesia, and then found an aberrant anomalous biceps that completely crossed over his median nerve. And what was happening when he was playing his mandolin is that he was developing this muscle that he hadn't really had to, which was then directly compressing his median nerve. Now, who would have thought? Right? Who would have thought I was going with exploratory because I was taking the leap. I was his Hail Mary. I was the person who said, well, I feel this with you. It doesn't come up on our ultrasounds, even with the best of ultrasounds, just looks like a regular here, but I will look. And what I found was something that we could resect and we could improve his pain. So here he is, able to do full extension, finished his PhD, and is back playing his mandolin. And you can see the tension that keeps. It's not horrible struggling, and he's very talented, but you can see where he could build up that biceps tendon. And so back to doing what he loves. And like, isn't that what we should be thinking about when we have patients in our offices with both nerve injuries or chronic neuropathic pain? So in summary, lean into your patients with pain. You don't necessarily have to be the one to treat it, and it doesn't have to take a whole lot of time, but I ask you to look for it. And if you find it, don't ignore it. Don't ignore it. Don't be afraid of it. Send them over to somebody who will care for it. If you don't want to care for it, it's okay. You don't want to care for it, but you wouldn't be on this webinar if you didn't really care. Refer early to your shoulder therapist. Align with your partners. Relationships with these colleagues matter. Don't be afraid to release multiple sites. And then you need to analyze your results and make sure that what you're doing is helping. And if we can do all that, then we can treat pain without it being painful. So thank you very much. And I will give it back to Steve and we can look at any questions that you may have for me.
Thank you, Dr. Moore, for outstanding webinar and talk on dealing with the complexities of pain. As a reminder for any attendees, please use the Q&A box if you have any questions. I just had a couple maybe to get us started. I guess one would be, what have you really seen like in the past year or two, or maybe 5 years, that has really like advanced care in pain? So is there anything? Is it the surgical techniques? Is it other factors that have contributed? Or I'm sure there could be more than one.
Yeah, no, I do think our technique, especially for neuromas, they're the game changer, right? So now knowing that we can't leave live wire superficially, like I think people are more um, leaning in to say, okay, let's deal with the nerve before it becomes painful. So I do think like that is there. Do I think compression neuropathy is new? No, it's not. Do I think releasing multiple sites at a time is new? No, but I think we go in waves of what we remember, the Lee Dellens, the Susan McKinnons, who have been releasing multiple nerves. I grew up thinking about it that way. I'm not afraid of it. I'm not a scratch collapse person where if I find the only one that's it. I went I skewed and only released one site, and then I'd come back and release others later. So now I'm just not afraid. I do think we're getting places with these different devices that can stop nerve growth when we need it to stop. I'm a big fan of amnion tissue. I know wraps are hot, and I don't wrap any nerve. I will do an onlay or an underlay. I want the material to go away. And that comes from experience of going back and seeing wraps that have been maybe put on too tight or that the body just doesn't tolerate. I don't think all ROPS are bad because I think the nerve is very attuned to where the environment of which is living. And if you can create an environment that's better than a scarred muscle, for example, or a bone that it's sitting against a plate, like these are where we need to lean in with our industry partners
Mm.
to make sure we're doing the right thing. And I really like the idea of these, nerve substitutes that are coming and that we have as access to not create more sites of pain. So there's a whole plethora, and I love being aligned with different groups, not because I feel like my allegiance is there, but more because I'm trying to search for my patients. We don't have all the right answers. There's 30 something or 30% patients that we have an opportunity to help.
Excellent. Thank
Long-winded.
you.
Does anybody ask a question yet? How about this? I'm gonna look at.
We had a couple thank yous. One,
Oh, look at that.
and yeah.
Yay. That's so awesome. Thank you, Jeff, and thank you, Carl. Good to see you or see you. Okay, well, you have more. What other questions can I answer?
Well,
I'm
my
sorry.
other question, you did such a nice job. From the GNF perspective, we're very passionate as well about this being a multidisciplinary
Mm,
team that it takes to care for peripheral nerve injuries and peripheral nerve problems. So I guess maybe for maybe the younger folks on the call, or even patients who are looking for how do you find these teams, or also how do you build these teams? So how were you able to kind of put this network together where you have the resources of PT, OT, and another pain management, imaging? Like how do you manage to pull all those folks together to care for patients?
yeah, that's a great question. And I think the most important thing to say is that it takes effort. And sometimes I feel like, oh, you just had it and it didn't have any work. I work really hard for my patients in the sense of, who do we need on board for them? And, I learned how to, at Wash U, I learned because I grew up with a very well established nerve practice, right? Susan McKinnon, Tommy Tung, Ida Fox, the list goes on of people who were, I was learning from. So I had all the resources already set out for me.
Mhm.
When I came to Ohio State, there was nothing of this, right? We had great hand surgery, that wasn't the problem, and I had great collaborators with plastic surgery, but I had to build it. And what that takes is um, communication, building the relationship with those. It's knowing that I can't do it on my own. I can do a really
Mhm.
great repair, but if I don't have that great occupational therapist, that hand therapist, that physical therapist, then my patient is not getting the best outcome that they could have. And so it started with me giving talks, me asking, can I get 10 minutes on your calendar? I mean, for some of the surgeons, I just showed up in their OR and said, like, hey, do you ever have any problems with patients that like are weak after their shoulder replacement or after a dislocation? Can you send them to me? Like, I promise you I'll take care of them and I'll give them back to you. I'm a no judgment zone because I think that's actually really critical is that I think when you have these patients with the less ideal outcomes, you could have done a perfect job on your surgery. and their nerves get irritated. And so,
Hmm.
and then there's this fear like, oh, they're just going to call that I was the bad surgeon. And so you have to reassure your referral, patterns and like protect them that I'm just here to help the patient and you've done the right thing by sending them my way. So building in relationships with people, I think that's how you build the team. Knowing you need the team is probably the first start. And then figuring out, okay, well, who else can help you with that? Who has the expertise or who wants to learn it? Um,
Right.
I think that was a really key part of my success at Ohio State.
Oh, that makes sense. Thank you.
Yeah, you're most welcome. Thanks for your question.
We did have a question about the use of MRI in TOS diagnosing, so for
Mhm.
thoracic outlet syndrome, and your use, or do you see using more of it in the coming years?
So I think where we're lacking, and we talk about this a lot actually, when we do these big meetings and I know we've been in these conversations about our imaging is not to the level that we want. And there's some really great radiologists who are doing amazing things with MRI and MR neurography, but if you don't have that technician or
Hmm.
that physician who's really has that MRI capability to like create it, um, it is not transferable. It's not all equal, right? So I always say I need a Daryl Sneed at Ohio State, or somebody who's trained by him because my images don't look like his images. And so MRI has its limitations. It will rule out the bad things, right? It will rule out the spinal disease. It rules out the tumors. It rules out the things that I worry about that could be bad actors for my patient who has pain and maybe weakness. But I'm not using it to rule in thoracic outlet. Again, for me, thoracic outlet is a diagnosis of exclusion. It's when I ruled out everything else and I've treated the imbalance of the shoulder girdle, that then I can say, all right, let's get maybe an injection to see if you have improvement. So I do use injections for them, or the patients have come with them. And Botox is the other part that I use to see, okay, if we weaken those muscles,
Hmm.
can we give you relief? So those help me rule in, but it's not an absolute. They're all just giving me the picture for the patients in front of me.
So even with the imaging, you would still want to rule out, kind of go through the exclusion of everything else.
Yeah, because I don't think the imaging is going to tell me. I've yet to see, and maybe it's seen me and I haven't seen it, but I've yet to see an image that tells me that nerve is compressed. I've seen it kinked after trauma. I've seen them take, oh, I lose it here, but it's never telling me, oh, this is thoracic outlet. It's just telling
Hmm.
me there's not a big tumor that's leading to this pain. Happy to learn. I mean, that's where it is. Like, this is where we need better imaging. I want somebody to take a pill and then I take some kind of like scan. This is where it's injured. This is if it's recovering or not. It turns this color to tell me, like, all these things. And I can say, okay, you're going to benefit from X, Y, and Z. And I think we'll get there. These fluorophores, these things that we can do. Have I resected far enough? Right? Am I outside the zone of injury? Like, imaging has such a capability, like ceiling that we haven't even gotten near, but we're trying. I mean, I
Right.
know there's a lot of people working on it.
Yeah. And that's where it goes back to the complexity of peripheral nerve care, right? There's so many technologies involved, so many people involved. Every area needs to kind of keep advancing in order to improve care.
Totally, totally important. It's great. Um, I think the other thing I see someone talking about painkillers, and happy to speak offline on it, but I will tell you, I don't know if you all noticed on um, my medications, there's no narcotic. I do not feel that narcotics treat nerve pain. They make us care less about it.
Hmm.
Now, if you define pain, and this I learned from Alan Bellsberg, if you define pain as suffering, and we're treating patients' suffering, narcotics can cause euphoria, which is a treatment of suffering, and therefore it would have a role. So it's not a bad thing if patients are being treated with narcotics. But too often I feel that we'll see patients that are on narcotics, but they have horrible nerve pain. And then they're expecting more narcotics. And I'm like, no, I want the neuromodulators. I want the non-narcotics because I think the narcotics aren't treating your neuropathic pain. Because if you take any of Volst, brachial plexus patient, you can load
Mhm.
them with as much narcotics and they still have pain. And you can only temporize it if you give them the modulators that are working on that brain pain. So I think like, the question is to ask more questions and continue to be an advocate for your care, and I will send you all that positive energy for that.
And we just had a nice comment from Jenny and thanking you for acknowledging PT and making sure that they're part of the treatment team and receive recognition as well. So thank you for that comment.
Yeah. Well, I always say PT, OT, hand therapist, make me look good. Like I'm a technician and they do all the work, right? And so I also grew up with Lorna Khan, who is a physical therapist, who was my partner when I went down the path of lower extremity nerve transfers. Because of her PT background, we could start thinking about, okay, well, how do we treat these lower extremities?
Mm,
Or how do we reanimate these free functionals or facial reanimation? And, I think not that the OTs can't do it, they all can do it, but like I just leaned in with her, and so mad respect for both specialties that can help our patients get to that next level.
yeah.
And we all are dealt with like people not seeing us. I think about that a lot with plastics, that when I go into these trying to get philanthropic donors for plastic surgery, the money is being sent to the person who treated the cancer. I was like, well,
Mm.
that the cancer was just part of it. See us. We are here with you for the rest of the longevity of that 360 care of giving you back your life. And so we all have that no matter what specialty we're in. And it's just, you just keep doing the work and that will come. Love
Yeah, and I
that.
think that's we talk about all the advances in surgical care, and I think there's just as much, right, in the PT/OT of how to deal with these new surgical techniques and how do you work with patients post-surgery. So I think there's a lot there that we as a Global Nerve Foundation need to also kind of work on getting the word out about, but it's such an integral part of care.
So especially with pain, right? Because there are ways that the therapists know that can help calm down their pain. And nerves don't like to be stretched, right? You stretch a nerve and you think like a stretched muscle, oh, just stretch it out, or a joint that's stiff.
Hmm.
Oh, just stretch it. You start stretching a nerve, you're gonna get more pain. But like, and I would say like initially I was like, oh yeah, just stretch it out. That nerve will stretch with you. No, 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 because it just drives more pain. And so I've learned so much from our therapists of like, okay, how can we best treat it? It takes caring about that, right? It takes
Yep.
caring about taking the time to listen to the patient and to your collaborators. It takes a lot of time.
Excellent. Well, thank you again,
Yeah,
Dr. Moore, for being here today, for
it was
speaking on this
great.
very important topic. Thank you to
Yeah, thank
Tissueum
you.
for making this possible as well. To all of the attendees, we will be sending follow-up information with the links to the recording, and we hope to see everybody on future webinars.
Yay, love it. Thank you so much.
Thanks,
Appreciate it.
everyone. Bye.